Hello, everyone. I've been continuing to hold what we used to call Lyme Hangouts, but so many of these sessions are dealing more with the science of Lyme disease. So it's been renamed Lyme Disease Science Conversations. And we certainly have had a lot of conversations. Having a second opinion is not exactly new in medicine anyway. There's been plenty of acceptance for someone who has cancer to get a cancer second opinion. If they have heart disease, do they need a bypass surgery? If they need elective surgery on the back, there's often a call for a second opinion. So I think that instead of saying, well, doctors are divided or my opinion stands, is that I encourage my patients to get as many consultations, as many second opinions as is appropriate for their symptoms, not to accept my opinion and not to accept other opinions as absolute. So I always encourage several doctors to be involved, to weigh in, give their perspective. But I think the Lyme disease second opinion is going to go a long ways toward making my patients feel comfortable asking me questions, asking other questions, and getting the information they need to work through what could be a potentially complicated illness. So I think if we look at this case, look at Lyme disease second opinion, and you think about your own health, is that for many of you in my audience, you're doing well. You have a doctor you're very comfortable with. You're well on the way to recover. You've been well for some time. So the most important thing is that if you know somebody who is not doing so well, is stressed and having problems, just call it the Lyme disease second opinion and encourage them to get a second look at what the issues are. I chose tonight to concentrate more on this all-important case. And I think this case may sound very familiar to many of you who've seen 2 doctors, 5 doctors, 10 doctors who've had some troubles getting better, who have troubles weighing the different treatment options. Sometimes the options of treating or not treating are actually so different that it gets confusing for you. It's certainly confusing for my patients. So the most important thing I find is that you have to get better. If I can't do it, if somebody else can't do it, you should stick with the goal of getting better. It's even if it's a struggle, you want a good outcome. You don't want to just say time's up, 3 weeks of antibiotics are done, and that's it. Or if you have psychiatric problems and psychiatric treatment isn't working, look if there's an organic cause, like a tick-borne illness. So let me tell you that about this case. This case was someone who was admitted, and the book, in this case, was a 37-year-old who was admitted to the emergency department. He self-admitted to the emergency department with a new onset panic, depression with suicidal thoughts. He had all kinds of somatic symptoms, that means a lot of physical symptoms that were involved. For 3 months, he had palpitations, tremulousness, chest pressure, choking sensation, and an intense fear of dying. Now, what's fascinating about this particular case is that he happened to have had Lyme disease 2 years earlier. At that particular time, that would have made him 35. He had fatigue, tinnitus, headaches, fever, flu-like symptoms a month after he removed a tick from his leg. Now, he had a positive ELISA test. He had 3 weeks of doxycycline, which is what the Infectious Disease Society of America always says is a useful form of therapy. It's just that my concern and working with Lyme disease over the years is that at least a third of people who get treated with 3 weeks are sick on long-term follow-up. usually the long-term follow-up is 1 year. And when they do trials, they've done trials longer than that. This 35-year-old presented, in this case, he was sick 2 years after his initial 3 weeks of treatment. So when he got to the hospital and was self-admitted, as I said, he had anxiety, suicidal thoughts, a lot of somatic things. He also had back pain, muscle spasms, weakness, tingling in his arms and legs, a lot of fatigue, poor sleep, low energy, loss of interest in his job, social activities, loss of appetite, 10-pound weight loss. He had been treated with antidepressants and anti-anxiety medicines for 2 months prior to being admitted. And the problem was that when he got admitted, with the 3 weeks of antibiotic history, he was not retreated. He wasn't offered any additional treatment. During the 9 days he was admitted at that hospital, he was evaluated. He was started on antidepressants. He was continued on a benzodiazepine called Klonopin. They gave him Remeron for sleep. So if I had been involved and offered a Lyme disease second opinion, if I had been offered that opportunity, I would have pointed out that 3 weeks of treatment works for some patients and not all patients. I think it would have been reasonable to at least discuss with the patient that doctors are divided. There's some doctors treat 3 weeks, some treat longer than 3 weeks. I would have done more testing for Lyme. I would have asked if they had a reinfection with Lyme. We do know from different research that some people benefit from retreatment. The Legigian did 2 papers in the 1990s where chronic neurologic Lyme and Lyme encephalopathy patients improved with antibiotics. I would have brought that into the discussion. Also, one of the NIH trials by Krupp, the fatigue improved. And so I would have at least liked to have had the opportunity during that admission to be called in for a Lyme disease second opinion and discuss whether retreatment might be useful. But in this case, the authors of this particular paper didn't discuss having discussed Lyme disease or some of the treatment alternatives that are out there. This author, Garakani, had published this paper in Case Reports in Psychiatry. And in this case, the patient was offered what you traditionally get offered, which is some antidepressant therapy and counseling. And when it was realized that he wasn't going to commit suicide or had thoughts of committing suicide, he was discharged for outpatient evaluation. In this case, the patient self-referred to a number of specialists when he got discharged, and that was probably because he had so many somatic complaints, he had so many other symptoms, and so many other problems that were out there that he went to multiple internists, neurologists. He had several Lyme tests. The Western blot Lyme test was negative. He included in his list of consultations and visits a doctor in another state who ordered a test for Igenix, IGENX. In this case, he didn't have positive Lyme test by the CDC, but he did have a positive for 2 bands, the 31 band and the 34 band. These are bands that are commonly seen in Lyme. They were bands that were considered for Lyme testing. They put these 2 Western blot bands away because they thought they would be positive from the Lyme disease vaccine. They're still of interest. You just can't call it Lyme disease based on the CDC criteria. Of note, the patient also had Babesia in the testing he had from this lab in California. He was treated with a total of 6 months of oral antibiotics. He had 3 months of tetracycline, 3 months of azithromycin and fluconazole. During that time, his brain MRI with and without contrast was normal. During that time, his cognitive deficits, which were important to him because he was working at the time, cleared. He no longer had panic attacks. He no longer had periods of hopelessness or suicidal thoughts. But he was still frustrated because he still had fatigue, weakness, low energy, pain and spasms in his back and upper legs. He still wasn't clear on what to do. I should take a break here and point out to you is that this paper allows, in a published paper in a journal, the sequence of events for this 35-year-old who originally had Lyme disease, 37-year-old admission, then he had treatment for Lyme. Now he presents to a outpatient clinic at the hospital to see if he could get some psychiatric care. He still felt he might benefit from psychiatric care. The author is realizing that there is an ongoing debate between doctors, those who will treat further and those who will stop at 3 weeks, try to define in this case report the difference between those who treat chronic Lyme disease and doctors who do not. And of course, that would probably be better to have a full discussion in a conference or full discussion during a panel. But the doctor did try as best they can to try to explain chronic Lyme. In this case, the author said chronic Lyme is seen by some doctors as a reasonable diagnosis, and other doctors say, well, they don't like the word chronic Lyme unless there's evidence of spirochetal infection. There's also, they talked about post-treatment Lyme disease syndrome, or post-Lyme disease syndrome, is that they said that can't really take place because when you are sick 2 years after the onset of Lyme, it can't be post-treatment. It has to occur within 6 months of the treatment. And in real life, real practice, that I find some people stay sick after 3 weeks of treatment, and some people it takes a couple years, as in this case, to develop it. So in this case, if they had asked for a Lyme Disease Second Opinion, they could have had a doctor from Infectious Disease Society of America say their perspective, which might have been that chronic Lyme doesn't exist, post-treatment Lyme disease does not apply. I can only say, from my perspective, is that some people benefit from further antibiotic therapy. In this particular case, is that he had 2 types of therapy that would seem rather logical, given he had neuropsychiatric issues. I call it neuropsychiatric because there was neurologic issues, psychiatric issues. So if I find a patient has tried doxycycline and other oral antibiotics, they still have neuropsych issues, it would be reasonable to at least consider intravenous antibiotics. Lyme crosses the blood-brain barrier. Sometimes you can't get across the blood-brain barrier without intravenous. There are those who criticize intravenous antibiotics for good reason, because there are side effects when you put a catheter in the forearm, like infections and clots. There's diarrhea sometimes. You can have some intravenous reception end up in the gallbladder. The benefits of intravenous ceftriaxone are from the case series reports from Krupp's trial by the NIH. Some of the intravenous studies didn't work very well, the Klempner and Fallon trials, but these people were sick for 4.7 years or 9 years. and they had already been failing treatment. And those trials don't apply to this particular 37-year-old man. So I think if I was given a Lyme disease second opinion, I would have considered intravenous rocephin. The other thing I would have done if I was called in for a Lyme disease second opinion was because the patient had a positive Babesia test. Babesia is a parasite that's in the same tick. The concern with Babesia is that it's only a short period of time that Babesia as a parasite stays in the red blood cells. It stays as a parasite in the red blood cells. And after it clears from the red blood cells, some people seem to feel apparently fairly well. They don't feel that ill. Some people are quite sick with Babesia or moderately sick. Some people think they're well and they donate blood, and then the recipient of the transfusion gets Babesia. But I think if you're sick with as many symptoms as this gentleman had, as many psych issues that he's had, is that he should at least be treated for Babesia at least once. Clindamycin and quinine were originally used, but they had a fair amount of side effects. By taking azithromycin with atrovacone, which we call Mepron, that has been much better tolerated. I often use Malarone instead of Mepron. It's better tolerated. You can take it longer. I find that I have to use clinical judgment. I'm not getting people better with Babesia in 10 days if they've been sick for a while. So my Lyme disease second opinion in this case would have been to go ahead with offer intravenous as an option and treat for Babesia at some point. Now, because this gentleman, this 37-year-old, had been sick now for 2 years, or at least, well, I guess it would be 9 months after he got discharged from the hospital. At this point, after being discouraged, he was no longer working anymore. He was pretty discouraged. And so the authors of this paper discussed some of the problems that this patient was having. I think, as a Lyme disease second opinion, that if there's a chance he was ill with Lyme, with Babesia, or with some of the other organisms like Borrelia miyamotoi, it'd be reasonable to do some counseling, but it would also be reasonable to look at antibiotics at another time. Now, what these authors said is that the infectious disease people, some of them say that these problems this gentleman had was called organically unexplained symptoms, or OUS. This often happens. Someone comes along with a definition, pulls out the definition and says, oh, they meet this definition. All organic unexplained symptoms means is that it's organic. Yes, they grant there's something wrong. It's unexplained and it's symptoms, and it doesn't lead to any clear treatment. The other item that came up was that one of the authors suggested that the symptoms may speak to this, what they call the tendency for patients to develop illusionary patterns of perception. For some reason, it's an illusion, these symptoms that they have. And so I'll say it again. The symptoms may speak to the observed tendency for patients to develop illusionary patterns of perceptions when they lack control. Now, that's a mouthful, to be sure. And I can imagine sitting there with my patient and trying to explain it's an illusionary pattern of perception. It might work for that doctor, but I'm not sure it's going to work for me. They did offer in the discussion, this author, is that the patient went through a prolonged period of uncertainty, was subjected to multiple treatment therapies, experienced new onset and distressing symptoms. This experience in its entirety could otherwise exacerbate the patient's presenting symptoms. So in this case, they're saying that being sick and tired for this long certainly weighs on a patient, and I agree. So in my Lyme disease second opinions, I will not only talk about treatment, but I'll talk about the burden of the illness, the difficulties trying to work or trying to go to school, trying to be a teen and have friendships. And I think counseling is certainly helpful, very helpful, rather than just pills. So they also had another statement I thought was helpful. The optimal approach in cases like ours would have laid somewhere in between biological and psychological. And I agree. Why not take a combination of biological and work through the psychology issues of being sick this long? I probably wouldn't have felt that this was the best care when the 35-year-old had Lyme for 3 weeks, treatment for 3 weeks. Then 2 years later was in a psychiatric ward. Then he spent 9 months trying to get some care, some workup as an outpatient. Now he's going to the psychiatric department. And I think that it would have been nice if people who know Lyme through a Lyme disease second opinion and those who know neurology and those who know psychiatrists are all working together at the same time. What they suggested, this patient would have received ongoing psychiatric care, including antidepressants, anti-anxiolytics, and psychotherapy. This author was suggesting that cognitive behavioral therapy would be useful, and no doubt cognitive behavioral therapy would be useful, but in evidence-based medicine, what sounds like a good idea, like cognitive behavioral therapy, seems like a reasonable good idea, but it would be nice to, at some point, subject that to trials for Lyme. I know it has some value for other illnesses like anxiety. It might be good to do a head-to-head between antibiotics and cognitive behavioral therapy. But since in my practice I do therapy as best I can as an internist, and I treat with antibiotics, I think the combination for some people is quite helpful. So if one looks at medicine, I thought that this case report in called Case Reports in Psychiatry that was published in 2015 did a great job of laying out a complicated patient, giving a great case report to highlight the benefits of a Lyme disease second opinion. I know a lot of you are out there and get discouraged if you hear that chronic Lyme doesn't exist. In that case, there's plenty of literature that talks about chronic Lyme disease. It may be a fight over what to call it. Should you call it neurologic Lyme, Lyme encephalopathy, neuropsychiatric Lyme, post-Lyme, post-treatment Lyme disease syndrome? I don't happen to like post-treatment Lyme disease syndrome because post-treatment gives the impression that Lyme disease is gone, and one can't ever be sure that Lyme or tick-borne has resolved. If you hear that there's no Lyme in your area, you should check a second time, because there's so many areas in the country where Lyme disease is much more prevalent, and even around the world. Every time they look, there's a variety of tick-borne illnesses around the world. Ask for a second opinion if you say that chronic Lyme or Lyme itself doesn't exist in the area. If you hear that tests are accurate, reliable, dependable, you should ask for a second opinion. Lyme disease second opinions certainly recognize that not everybody has Lyme, but not everybody has a positive test either. If you hear that 3 weeks of doxycycline is all you need, well, that works for 2/3 of people, but 1 out of 3 is not going to have a good outcome. And there hasn't come up with another evidence-based treatment alternative. Every trial for Lyme and tick-borne is complicated because they're really small. They usually enroll people who failed treatment already. They've often enrolled people who've been sick for years. And so in practice, if you have sick patients, if you look second time at the evidence as a doctor, you're going to find that it's pretty disappointing. So whenever you're ill, you might find that that doctor does a great job, tells you exactly what to do, tells you to get treated, get started, follow up. But sometimes it gets rather confused. You're just not sure if you ask all the right questions. You're anxious. Why not get a second opinion? A Lyme disease second opinion. One more thing I'd like to mention is that I'd like to start looking at closing tonight's session. My moderator is not able to log in, so I'm going to close myself. Don't forget that that I have a book, Lyme Disease Takes on Medicine, that is based on a whole series of Lyme disease science blogs that I write. I still continue to write Lyme disease science blogs on articles I read. I continue to write and communicate through my Facebook, through Instagram, Pinterest. Very importantly is my office has been working really hard to prepare for an event. Because of the book, is that they thought, why not celebrate all the work I've been doing, and inviting friends, supporters, those who are out there in this in the audience to come and join me on the 9th, which is a Saturday, from 4:30 to I believe 8 o'clock, 7:38. We're going to be having a time to meet me, time to meet my staff. There'll be some patients who will be giving some of their stories, sharing their stories. There'll be some games and those and other prizes, and it's just a way to get me to take a break, stop writing for a day, stop these kind of things, and just enjoy an evening with anybody who can make it. There'll be a book signing time. That'll be the 9th. So if you want to RSVP, do it through the social media, or you can send an email to info@danielcameronmd.com. So I wanted to close by saying, listen, you're all fighting to either get better or help somebody else to get better. These Lyme disease science conversations are another way to start working through some of the conversations we need to solve Lyme for your friends or your loved one or even yourself. So I'd like to close by thanking you. I fight with you guys. I get find some frustrations like you guys, but I'm still there. You're there, and so together and this whole community can try to work through in a conversational format how to come up with a better answer for Lyme disease. Thank you.